Welcome to Dental Business RX. Practice success in 30 minutes or less.
Thank you for calling ABC Dental.
Is your practice ready to add an associate? Is this something that you've been considering? Well, from experience, I can tell you that adding an associate can range from being one of the best business decisions you've ever made to something that you regret horribly and that gives you nightmares years after you've ended the relationship. So what makes the good scenarios good and the bad ones bad? For the most part, it's a combo of four factors. The first one is having an actual business need for an associate doctor to move your practice to the next level. The second one is determining how you plan to utilize this associate. The third is finding the right associate that fits your particular situation. And the fourth is ensuring that you keep your practice expanding and support your associate as the practice grows. These four factors, or lack thereof, are what make good situations good or bad ones bad. And sure, there are other factors and considerations that come into play. But if you were to distill things down to sort of the bigger points, these 4 points seem to loom the largest. And it's this first point, how to determine if you're actually ready for an associate. See if you actually have a business need to add one, that I want to talk about in this week's episode. My name is Jeff Bloomberg, and I'm your host, and I chose to give this topic its own episode because taking on an associate when your practice isn't ready for it is probably one of the bigger mistakes that we see people make. Why? I couldn't really tell you because every situation is, I can, but it would be a number of explanations because every situation is different. But there are certain business metrics and situations that you want in place before you bring in this associate doctor. And if they're not in place and you bring somebody into that mix, that's when you start to get into trouble. That's when you start to, you're sitting in your office while your associate is doing treatment that you should be doing, or you're working and your associate is not busy, or there's massive amounts of disagreements on what the associate is supposed to do and not supposed to do. If you don't have these things in place, certain things in place before you bring them in, this is when you start to see the messy side of the owner-doctor and associate relationship. So let's say this is you. You're thinking about, I should get an associate, and you want to determine, is my practice ready? Well, if you were to sit down with me, there's a few things I would do with you. The first thing I would ask you is, why are we adding an associate doctor? Now, the usual answers I'll get to that question, there's two main answers. The first one is, I'm too busy. I'm booked out, I'm running out of 3 chairs, etc. I need somebody to help. That's the first reason I'm usually given. The second, less common reason is, I want to bring somebody in to do procedures that I don't do. Maybe you don't place implants or don't want to place implants, and you want to hire somebody to place implants. Okay, so those are the 2 reasons we normally hear. And the handling for those 2 reasons is different. So let's pick up the first one. Let's say you go, look, I'm just crazy busy. I'm working out of 4 chairs. I'm booking patients. If you want a filling done, you're going to be waiting 8 weeks. I don't have any time for myself. I'm working 50 hours a week, and I'm just too busy. Okay. So there'd be a few things I'd want to look at with your practice before I say, sure, add an associate, because you might just have a disorganized, messy situation that isn't profitable. If I throw an associate into that, it's just going to get worse. So the first thing I would look at with your practice is, are you profitable? Now, I'm going to give a specialized definition to profit here because, profitable could mean that you're making $1 more than your practice spends and you're not taking any money home. Profitable is a relative term, right? It could be very profitable or not, barely profitable. But to me, a satisfactory level of profit in a dental practice, I'll give you a basic calculation. I actually think I talked about in this week's or the prior week's episode. It's real simple. If you were to pay yourself as the doctor owner, as an associate doctor at 30%, okay, at 30%, and I'll give you some numbers here in a second so you can kind of run through this. Do you still have on top of that an additional 20% of profit? Okay, so I'll say that again. If you were to pay yourself as an associate doctor, for the work that you do as the owner doctor, would you still have an additional 20% of profit in the practice? That's a profitable dental practice. So let's use some real numbers. You have a practice that's collecting $100,000 a month and producing $100,000 a month, and the doctor owner is doing $70,000 of that $100,000. All right. Well, what would you have to pay an associate to produce that $70,000? You'd probably have to pay him at least 30%. That would be $21,000. Okay. And so what I would want to see is that if you paid yourself $21,000 as the owner doctor producing 70 of that 100, do you still have an additional 20% of profit? So if you broke the numbers down, it would go 100,000 in collections, 20,000 in profit, 20%, and 21,000 paid to you as the associate. I'm not saying you should pay yourself as an associate. These are just health numbers I'm looking at. What that works out to is 41%. So I would want the practice overhead to be 59% or less. That would be a profitable practice. Now, I should also mention, if you have debt service, say you're paying a loan back and, I'm not getting into an accounting thing here, but this is just to factor in, are you profitable or not? Let's say you're paying $10,000 a month in debt service or $11,000 rather, and $1,000 of that is interest and $10,000 is principal. Well, that $10,000 would be weighed against your profit. So I would count that in that 20%. So let's say, again, $100,000 in collections, $10,000 in debt service, and an additional $10,000 in profit, plus paying yourself as if you were an associate $21,000. We still have our overhead at 59%, right? Or less, 59%. I may have gotten the number wrong earlier. Sorry. It's just a percent. Then I would consider that a profitable practice. Before I'd go throwing an associate into this mix, that's what I'd want to see. Now, why wouldn't you be profitable? Either A, you're not being effective with the time that you're spending in the practice, which I'm going to talk a little bit more about, or B, your case acceptance is low. You could also just be spending too much money, which is a whole other thing. Your case acceptance is low, because one thing to think with case acceptance is if you're presenting six crowns to a patient, if you actually know how to close that case, you could spend the same amount of time closing 6 crowns that it takes you to close the 2 that insurance are going to cover. All right. But the difference to your practice is huge. It's a $4,000 difference plus to your practice. So that's going to have a large bearing on your profitability. Okay. And it didn't cost you more time. Do you see? So first thing I want to look at, again, you've come to me, you're super busy, you're overwhelmed, you need an associate. I would say, okay, are you profitable? And we'd look at your numbers. And if you're not profitable, we'd have to resolve that first. Second thing I'm going to look at, assuming you're profitable, is are you properly scheduled? As the owner doctor or as the main producer, are you properly scheduled? So what does that mean? I'm not going to do a whole scheduling podcast here. I actually have some episodes and I'll refer you to them here. But I'm going to want to look at A, are you properly double booked? And just to be clear, what does double booked mean? It does not mean you're working out of 2 chairs with 1 dental assistant. That's not double booked. That's just switching rooms. Double booked, properly double booked would mean you have a scheduling system, which I'll talk about in a second, and you have an assistant in each room. Okay, so you're not scheduling linearly. All right. You're scheduling where, patient A comes in at 8 o'clock and let's say it's an hour and a half procedure. And the first 10 or 15 minutes of the appointment, the assistant is getting them seated and set up. And then you jump in the room. And then towards the end of patient A's procedure, patient B is being seated by assistant 2. Do you see? So it's flowing. You end up being able to see a ton more patients and be a lot more productive. Okay. Which means that you need on your schedule proper organization. The schedule needs to be properly organized. You have and schedule policy on this. You have scheduling procedures. There's, primary time, secondary time, tertiary time, where you're doing big procedures during certain periods of the day. And the schedule policy is actually being followed. That's the other thing. You could say, look, I only want to do primary, meaning large dollar value procedures in the mornings. But then you come in and you're doing a bunch of deliveries in the morning, and then you have, you're prepping some crowns at 4:30 p.m. tonight. Even though your policy says primary times in the morning, that means, you have policy, but the policy is not being followed. Okay. So I'd want to see, are you scheduled properly? Are you properly double booked? Is your schedule policy being followed? And the next thing I'm going to want to see is, do you actually have time baked into your schedule to sell? I've talked about this a lot in prior episodes, but in order to sell, you need 3 things. 1, you need somebody who actually needs something. In other words, here's a patient. They have treatment that needs to be sold to them. That's the first thing you need. The second thing you need is sales skill. You need to be able to close. And the third thing you need is the organizational side of sales, part of which is time to sell. If you don't have time baked into your schedule to sell, because we bake in time for diagnosis, exams, and we bake in time for treatment. If you don't have time baked in for sales, you're not going to close as much, even if you're a great closer, because I mean, let's say, I want to present a $10,000 case to somebody and I only have 5 minutes, but let's say I'm a really good closer. Well, I'm not going to close that in 5 minutes. It doesn't matter how good I am because it takes me 20 to properly explain everything and answer all of their questions, or maybe 30. All right. So time has to be baked into your schedule to sell. So I want to see proper double booked, schedule policy set up so that it's organized, and I want to see time baked into the schedule to sell. So you'll be busy, you'll be efficient, you won't be on roller skates rolling between 3 or 4 operatories. That just does not work. Now, if you want more data on this, as far as how do I organize my schedule, I have a few things you can look at. We did a few episodes called Designing the Ideal Schedule. Back episodes 49 and 50 here on the podcast you can listen to. We also do a free seminar here at MGE called The Art of Scheduling Productively. I put a link to it on the episode webpage. It's a couple hours long. Between the podcast and the seminar, you get some basic data on scheduling organization. If you really want to dive deep on this and learn, how to really make an effective schedule, I'd suggest 2 other things. On our online platform, DDS Success, we have 2 courses. One, The Art of Scheduling Productively for the whole team. We also have schedule coordinator training. This gives you the whole system. I'll put a link to it on the episode webpage along with a discount code. And here at MGE, we do a seminar called Scheduling for Production. I'll put a link to that as well. That was a lot, right? But let's say that. So this was you. You came to me. You were busy. We've ensured that you're profitable, right? Which means we've taught you how to sell, which is important. And we've organized your schedule so that your schedule is running efficiently, all right? So now, do we add the associate yet? Not necessarily. Sure, we're efficient and we've maximized our chair time, but what if we're in network with a lot of plans? Because that's a distinct possibility that happens with a lot of dentists, right? Let's say 80% of our patient base is in some form of PPO. The average fee haircut I'm going to take, the discount, the write-off that I'm going to be giving with a PPO is probably about 30 to 40% for basic and major procedures and close to 50% for preventive and diagnostic. Okay. So what I'd probably do before I added this associate, I've maximized everything, right? Is I would start dropping plans. Okay. Because I'm doing crowns for $800 right now. I should be doing them for $1,400, which is my normal full fee. Now, if I start dropping plans, obviously I want to do this intelligently. I'm not going to just dump them all at once. There's smart ways to do this. I've talked about that in other episodes. And look, if you have questions about this, sometimes, especially for something that critical, look, I'm not telling anybody. It's a funny thing about the podcast. We're just throwing the data out there. Someone could take this data and use it and be very successful. And that's fine. That's why we do it, right? In certain cases, I know for me, I might be a bit nervous if I was very heavily involved in plans and I'm just going to start dropping them. Sometimes it helps to talk to somebody. This is why we're here. You can call us. I'll put our contact info at the end of the episode. We can kind of walk you through the process so you can do it in the least scary way, especially if it's a large portion of your practice. But when you start dropping plans, there is a chance that you're going to lose some patients. Now, if you do it right, you can keep that loss at a very, very low percentage, maybe 10% or 15%. The average loss when you start dropping plans is 30%. That's the average. Sometimes it's higher, with Delta or something like this, just because Delta tends to become very aggressive when you drop them. They're just, it's just how they are. But there's even ways around that, or to combat that rather. Most plans just, you drop them, and there's certain things you're going to want to do within the practice. You have to have the staff coached on exactly what to tell patients, how to handle patients when they schedule them. What if patients are upset or have questions? You want to have this all wired before you drop your first plan. Okay. Unless it's a, really tiny plan with very little participation. But so if you're scheduled efficiently and things are maximized, right? Then I'm going to probably, if I'm very heavily involved in plans, want to drop plans because I might thin out my schedule a bit when I start doing this, in which case we'd have to get into some reactivation efforts and marketing efforts to sort of fill the patient roster a bit. But then the immediate result of that when I start dropping these plans is, I'm working the same or possibly less, but practice revenues are going to go up 30 or 40%, possibly more. All right. So, and I still haven't added my associate yet. I've just become more efficient and more effective. All right. And it's going to increase my margin. There's something you can think with. If you want to think with something, and if you've been in the industry for a while, like if I'm specifically addressing dentists who were practicing in their early 90s, I survey this in the seminar room when we deliver seminars here. I'll ask, how many people were working during this period. during the 2008 real estate crash or during the mid 90s. And those hands, I'm seeing less and less hands every year. So I'm starting to feel like a little bit of a relic. But anyway, you ask any dentist from the 90s what their overhead was supposed to be, you would have heard a uniform 50% from just about everybody. That was what your overhead was supposed to be when you ran a dental practice. 50%. So if you were collecting $60,000, you should be taking $30,000 home. That was standard. Okay. That was standard. Now, the reason why it is no longer 50% when you see most overheads, and I've looked at a lot of overheads, is, how do I say this? It actually is, but it isn't. Let me give you an example. So let's say you have a practice that at full fee would be collecting $150,000 at full fee. All right. But they're involved in a lot of PPOs. So they're writing off $50,000 a month. So they're really collecting $100,000, right? But if you were to do this at full fee, it would be $150,000. Now, funnily enough, when you look at their overhead, in a lot of cases, it'll be $75,000 or $80,000. So think with this for a second. Place is collecting $100,000, but the overhead is $75,000 or $80,000. So obviously the overhead is 75 or 80%. But if they were to charge full fee, they would actually be collecting $150,000, and their overhead wouldn't change one iota, because it's not like you're just getting a lower fee, you're being reimbursed a lower fee, or you've agreed to a discounted fee schedule. Just because you've agreed to a discounted fee schedule doesn't mean that your rent is with a 30% write-off. Your staff want to still be paid the same. Your lab still wants to be paid the same. So does the supplier. So does everybody else. So if you were to factor that in, your overhead really would be 50%. That number still holds. It's just that the fees have been all screwed up over the last 30 years, or 20 years rather. So this is something that I would do. The next thing I would do, you're maxed out, you're efficiently maxed out and productive, start dropping plans and you'll start to see revenue go up. Now, assuming you're now fee for service, you're scheduled efficiently, and you've maximized production, and you've hit a point where now you're busy, now it might be time to add an associate. You might be listening to this and go, Jeff, I would never wait that long. I'm real busy. I'm taking all these plans and I'm just super busy. I'm just going to add an associate now. And you can. And have I seen that work? Sure, it works okay. It's not super profitable. I've also seen the scenario I'm explaining to you play out in a lot of different ways, usually very favorably. I think of one client in particular he had an associate eventually, but he dropped all his plans and he got down to the point where he was working 18 hours a week and collecting $200,000 a month and coaching his kid's baseball team because he had time, because he was fee for service. He didn't even want an associate at first. Then as things started to get busier, he didn't want to add more time, so he added an associate doctor. But he was maxed out. When he was at the office, man, they were running. Right? They were working, but it was fee for service. So you could take that step or not take that step. I think, a few years back, you might have, I would have, if someone was giving me pushback on that, I might not have said anything. These days, especially with inflation being over 20% the last 4 years and reimbursement in a lot of cases with insurance companies being lowered, I don't think it's a smart move. I think if you are in network, you need to start thinking about how you're going to get out, because in certain cases, it's going to take time. And start the journey now, because you may not be out for a while. All right, so let's say this is you. You've now hit a point. Again, like I said, you can add an associate earlier if you want. I'm just sort of giving you some guidelines if you want to do this effectively and profitably. But let's say this is you. You've maxed out your productivity. You're efficient. You're now starting to book out. You've got a fee-for-service practice. Things are just rolling along and it's going well, right? So what's next? Now you got to add this associate doctor. What would I want to see in your practice to know that you could support an associate doctor? Well, as a GP, because specifically I'm talking to GPs here. If you're a specialist, if you're a periodontist, an oral surgeon, different conversation, happy to talk to you. But as a GP, I'd want to see two basic things. We need some volume to support this associate. And this doesn't even take into consideration how you're going to use the associate. All right? Let's assume it's a traditional associate setup. You're bringing in a doctor to do the type of work that you don't want to do. The emergencies, you want them on call. They can do the fillings. They can do the single units. They can do the kids, things like that, right? You want to focus on more high-end procedures. Fine. All right. So what would I want to see in your practice? Well, number one, I want to ensure that we could get at least 20 new patients a month to support this associate. It could be less, at least 20. I'd like to see more, but it could be less if you're going to start them part-time. All right. So maybe you're not getting that extra 20 new patients a month right now. Now that would be on top of whatever new patients you're getting for you. So you're seeing at least 30 plus yourself. And then we're going to add an additional 20 for this associate doctor. So you at least have to know you have the ability to do that, or you're getting that now. That would be the first thing. Second thing, I would want to focus on the doctor to hygienist ratio. And I've talked about this. Oh gosh, when you've done this many episodes, you don't remember when you talked about something, but, I've talked about this before. Ideal doc to hygienist ratio is 1-to-1 or 1-to-1.5. Meaning, if you have two hygienists and you have one doctor, that's a bit tight. If you are having to get up in certain cases twice an hour to go do a hygiene exam while you're trying to be a productive doctor and have time to sell and do new patient exams and everything else, I'm not saying you won't be productive, but you would be less productive than if you only had to get up once an hour. Okay. So 1 to 1.5 seems to work. If at certain points during the week you're getting up twice, fine. But if the other points you're only getting up once, that works better. So if it's you and one full-time and one part-time hygienist, that works. Okay. If it's you and two hygienists, you're pushing it a bit. If it's you and three hygienists, you're going to be less productive than a doctor with two hygienists. Okay. Unless the hygienists are super productive, but the doctor production is most likely going to go down. So if it's you and three hygienists, you have enough hygiene traffic to add an associate at that point. No problem. If it's you and two, you probably have enough to add a part-time associate. In certain cases, I've seen people say, well, I have the hygiene patients to fill up a third hygienist. I just don't have I can't find a hygienist. Well, I said, add the associate, have them do hygiene part-time and doctor work part-time. May as well, to keep the person, keep them busy and keep things going. And as they get more and more involved in being, doing dentistry, you can find a hygienist in the interim. And then now you've got three hygienists and two full-time doctors, right? But this 1 to 1.5 ratio seems to work best. And the only time I've seen people be able to sort of circumvent it is if you have a heavy, heavy, heavy amount of new patients. You have a practice that's seeing 100, 150 new patients a month. Well, gosh, and they've got one part-time hygienist and one doctor. Most likely you can afford an associate, or you have the volume for an associate. But as a GP, again, I'm talking to you about the most stable way to build up and add an associate. Not a great way to go, because you're missing out on that whole hygiene program that should be keeping your practice busy, for years to come. And you're also probably blowing it with regards to patient retention unless you're doing a bunch of cleanings yourself, if you've only got a part-time hygienist and seeing 100 new patients a month. And that sort of defeats the whole point of being a GP. You see, if you're living off of your new patients, then you've essentially turned yourself into a specialist, which, nothing on specialists, that's their business model. But as a general practitioner, the majority of your revenue should be coming from patients of record that are regularly cycling through hygiene, as well as then you get the new patients on top of that, which then increases the number of patients of record cycling through hygiene. Okay. So look, you could add an associate earlier than doing all the things I've described, or you could start with somebody part-time, which is sometimes an easier way to go. For the most part, though, what I find is if you get yourself efficient first as the doctor owner, and then you drop the plan so you've maximized profitability and you've got a healthy practice at that point, that's the most comfortable way to move forward without creating, major amounts of waves. What we don't want, again, is you chilling out while the associate is doing work that you should be doing, or the associate sitting around with nothing to do and you're having to pay them a per diem or something like that. You're basically paying for a super expensive hygienist at that point. That doesn't work for them. That doesn't work for you. The associate should be busy, and really, truthfully, you're going to just be less profitable. But adding an associate should increase your profitability, not necessarily your percentage of profit, but the amount of profit. I like to compare it to getting a smaller piece of a bigger pie. Maybe you were collecting $100,000 a month on your own at 60% overhead or 55% overhead, so you're netting $45,000 a month. Well, now you've added an associate doctor, which there's a sort of a synergistic thing that happens if you do this correctly. Number one, the associate themselves are productive. So let's say they do $50,000 a month. That wasn't being done in your practice before, but because they're taking these things off your schedule that was sort of weighting your schedule down, you're now able to focus on larger procedures as the owner doctor, and you become even more productive. So if we take a practice again, it's doing $100,000 a month with the owner doctor doing 70, hygiene doing 30. We add an associate doctor. Now that associate's doing 50, hygiene's doing 30, which is 80, but then the owner doctor's production, because they're not doing fillings anymore, now goes up to 100. So now the place is doing 180. So yeah, is your profit margin lower at that point? As a percentage, yes, but as an amount, no. Instead of netting $45,000 a month now, you're netting closer to 80, you see, or maybe you're netting 70. So, which is a lower percentage than 45%, right? But, or 60 even. But the amount is higher. All right. So that would be what I would tell somebody if they go, look, I want to add somebody because I'm too busy. Those would be the things I'd run them through, and that would be the process I would run them through. Would everybody follow through on each and every step and drop every plan? Maybe, maybe not. That to me is how I would personally do it. Tends to be the more rewarding way to do it. What we see a lot of people do these days is they do that with their main, primary practice, and then they buy another office and they stick an associate in there and do the same thing, right? And I talked about that in last week's episode. All right, so now let's look at this second reason that someone might want to add an associate. They want to add an associate to do things that they don't do, okay? And this is not dissimilar really to adding a specialist. Let's say you have a lot of complex extractions walk into your practice and you think, well, geez, if I hired an oral surgeon, they could come in 1 day a week and see these patients. If you were to do that, the usual business model for that is you pay 50%. The reasoning being, if you refer them out, you're getting 100% of nothing. In this case, you're getting 50% of something. Not bad reasoning. And that works still, for perio surgeries or things like this. I mean, endo might be a bit tricky because you got to get that root canal done now if you're referring all your endo out. But what I've seen, especially the last few years, is let's say you don't place implants and you want to bring somebody in who does. And what I'm seeing in these cases is if you're paying them as a 30% associate, that works best. But I'm seeing the number 40% pop up more and more. So you're a GP, you're rolling along, you restore implants, you do all types of other dentistry, and you bring in an associate who places implants. And you're going to pay this person 40%. So if you're feeding, there's two things you want to consider if you're going to do this. Number one, whatever you have to have a profitable office. Okay. And I would use that same definition of profit I used earlier in the episode. Assuming my office is profitable, this is not necessarily a bad thing to add this associate, even if I'm paying them 40%. I'd rather pay them 30, but even if I pay as high as 40, it's not the end of the world. Maybe they're eating the implant costs and any, if they're restoring the implant, maybe they're eating the lab fee too. Okay. Or we're splitting, or if it's 40%, I'm probably not going to split it. 30%, I might split it, but that's fine. We can do that. But there's a couple of things I'm going to want to look at. If I can organically keep this person busy, then that works. So I would first have to look at how many patients am I seeing in a week, maybe that I've been referring out, or in a month that need implants. Okay. So let's say I'm seeing 4 or 5 patients a week who need implants. And so, I'm seeing roughly 20 a month. Well, I could probably keep an associate busy 3 or 4 days a month. Well, prepping them or placing them rather, and then they eventually have to restore. Maybe how many days? That's going to be 6 days or whatever. With just the implant traffic I already have resident in my practice. So that's going to cost me nothing. I'm going to bring this individual in, this associate doctor, and I'm just going to have my patients see this doctor. I'll sell the cases or have the doctor sell the case, whatever works out best for you. And that doctor is going to place those implants and restore those implants. Maybe they did the bone graft too, however you want to do it, right? That works because I didn't spend any marketing money to obtain those patients. There was no acquisition cost. Now, if I'm going to spend marketing money to feed implant patients into this practice, I'm going to do an implant funnel or something like this. Well, there's a couple things I'm going to want to consider. Number one, I can't let that mess with the current marketing that I'm doing that's keeping my practice going as the GP. I've seen people do this. They drop a bunch of money in implant funnels, stop doing what they were doing, and they're basically selling out for implants, but they don't even place the implants. So they're already paying 40% to the associate. Now they're spending marketing money, and they end up actually losing profitability as a result of this. So to reiterate, if you can do it organically and keep the person busy a day or 2 a week, hey, go for it. Sounds great. If you're going to do the marketing, you have to do it sort of parallel to what you're already doing in your practice. You can't let anything in your practice change, and see if it makes money. Because then if let's say I'm doing implant funnels or implant PPC or something like this, pay-per-click, and I see that I'm spending more than this doctor is making in the practice, this is just a loser for me. This isn't going to work. Maybe I have to dial it back to where we're just doing it organically now with the patients that I heard already coming into the practice. All right. But this is what I'm thinking about before I'm adding. I'd have the same consideration if I were adding a specialist, even if I was adding a specialist to place implants, right? I'd want to make sure that organically I could support them before I even brought them in. And you got to be careful that you're not just cleaning up a backlog. And what do I mean by that? So let's say, I don't know, in the last 3-4 months, you've seen 60 patients who needed implants. But then if you look at it over the course of the year, it's really not that many. They just happen to all come in during that 3-month period. So they're going to come in, and the first few months are going to look great as they do those 60 patients. They do those implants on those 60 patients. But after that, it gets to run a bit dry. They're not busy. You feel bad. So now you start spending marketing money to keep this person busy. You see what I'm getting at. So again, organically, or if you're going to spend marketing, it has to make money. So I guess, determining whether are you ready for an associate doctor or not, those are some of the criteria I would look at. And there's the other factor, which I didn't really get too much into. If you're working a lot, and you just don't have a lot of free time, again, a lot of that would be handled by addressing your schedule, dropping plans, possibly improving your ability to sell. Those 3 things would address a lot of that because, if you do that, you're going to drop a lot of that traffic. And if you're still busy afterwards, then the associate is the way up. So assuming your practice is profitable, hygiene's healthy, and you're confident you can support the associate that you hire, this could be a win-win. If not, you run the risk of things going wrong. You're not busy enough, the associate isn't, you're not profitable, and so on. And I'd rather handle that before it becomes a problem. So maybe, don't jump into it too fast if your practice isn't ready. And again, if you have questions about this, you wonder, well, am I ready? Am I not ready? We are more than happy to help. You can always reach out to me via email at jeffb@mgeonline.com. I've had a lot of listeners do that and ask questions just along these lines. Happy to answer them. You can also reach us here at MGE at 800-640-1140 or reach us online at mgeonline.com. Put those links to those different scheduling podcasts and videos and seminars on the episode webpage. Otherwise, folks, I hope this helps. Have a great week, and we will see you at the next episode.